Okay, welcome back, everyone. And we're going to start with our keynote address. We're very privileged and very pleased to have with us a special guest for our keynote speaker, and that's Dr. Shannon Hader. Dr. Hader is currently the Deputy Executive Director of Program at UNAIDS and Assistant Secretary General at the United Nations. She's trained in pediatrics, internal medicine, and infectious diseases, and has worked in a variety of roles in the HIV fight across the world: clinical, uniform services, local health department, private sector, the U.S. Centers for Disease Control and Prevention, and United Nations. Dr. Hader has a very strong focus on delivering results for people, promoting investments in community-led responses, and driving innovation and change. Dr. Hader, thank you so much for being with us today, and welcome, and I turn it over to you.
Great, thank you so much. I'm going to go ahead and thank you, my co-chairs, as well as the conveners, for the ability to be here with everybody today. Thank you to the participants in particular. I know these are crazy wild times. I hope this fantastic conference gives you a little bit of a brain space and a respite to re-energize for the day-to-day work that you're definitely doing. So I was asked to talk here today on Universal Test and Connect, which I guess the question is this a new approach for a new time, a COVID or post-COVID era? And what's that all about? So first, I wanted to do a quick check-in. 2020, where are we now? Certainly, we maintain the 2030 goal for HIV, which is to end AIDS as a public health threat. We have made tremendous progress on HIV, even though we have lots left to do. We entered 2020 at a time when universal health coverage is a high priority around the world. There's lots of interest, but it was far from achieved. And I think we have increasingly heard a common desire to better and more meaningfully integrate services that serve clients' needs and desires. And then, of course, we got COVID-19. So, where really are we at? Some of you heard me talk at the Fast Track Cities conference earlier this year, where I mentioned, before COVID-19, we were not as a globe on track to reach the 2020 Fast Track targets for HIV, which were a 75% reduction in new infections and in death from AIDS by 2020. These graphs here, the blue shows only a 23% reduction overall in new infections since 2010, far above that blue dot, which is our target, and about a 40% decrease in AIDS-related deaths since 2010. So much better, but still above where we wanted to be. That said, progress is variable. It's highly variable, and these global numbers don't do justice to just how much variability there is. Variability across regions, within regions across countries, and within countries across subnational areas and populations. In fact, some countries are doing extremely well on these targets. And because we're going to talk about universal test and treat, let me do the vision also of where we're at in the global treatment cascade. Of course, 90-90-90 translates as a cascade to 90-81-73. The goal is 73% of all people living with HIV have a fully suppressed viral load. And again, here you see we have made together tremendous progress. 25.4 million people in the world on ART. But that means there's still 12.6 million people across the world not on life-saving treatment right now. And those are who show up in these orange hashed areas of the gap. As I mentioned, some countries are doing extremely well. Two countries that have already surpassed 95-95-95 are Eswatini and Switzerland. So you couldn't find two more different countries and two more different epidemics, and it shows you it's truly feasible to fill the gaps and accelerate. But even when we look across the world at countries that are doing fairly well, we find not everybody is being equally reached, even within a single country, within a single community. And more often than not, certain groups are less reached than others. And this includes men, young people, and key populations. And this graph just shows and reminds us that men pretty much across the world living with HIV are less likely to know their HIV positive status, and that drives disparities through the rest of the treatment cascade. And even in situations where a good high milestone is reached, like 95%, it's not truly universal when specific groups are missed. And this shows where Zimbabwe has done incredibly well, with 95% of women living with HIV knowing their HIV positive status. But then when you look at a specific community, you look at transgender women in Harare, and you find only 36% of those women know their HIV positive status. And that is the limiting factor for them achieving equal second and third 90s, is really that first 90. So that's where we were at before we got COVID. And then, of course, COVID ended up taking over everything. Pretty early in the COVID epidemic, UNAIDS with WHO and other partners did some modeling. And we said, well, what if? How bad could it get? And we said, well, what if HIV treatment services, for example, were just put on pause or fully interrupted for 6 months in sub-Saharan Africa alone? And our modeling showed that if that happened, we would double the number of deaths from AIDS on the continent alone, going back to 2008 death rates, and essentially we'd lose a decade of progress in just 1 year. But when we look now and see where we're at, and this is data from July, we find for HIV treatment services in particular, we have seen some dips and some recoveries that indicate actual treatment coverage remains a lot more stable than that worst case scenario. But that's not by accident. That's due to actions taken every day by people, by providers like you, by people living with HIV and community-led organizations, by partners and donors who have really gotten together to fill the gaps and keep making a new and agile way to deliver services. We don't see quite the same recovery or stability in other types of HIV services, from harm reduction to prevention, etc. So, UTT, Universal Test and Treat. Why are we talking about UTT at this time? And I think to understand why we might be talking about UTT in 2020, we actually have to flash back to 2013, which is when Universal Test and Treat came up as a thing. And so where were we all at in 2013? It's sometimes hard to remember how quickly things have changed. So in 2013, Treat All was not yet a thing. It wasn't until September 2015 that WHO full recommendations on Treat All came out, and it was the 2016 UN high-level meeting commitments to a global 90-90-90 fast track that happened. But even though those guidelines and commitments weren't there yet, there was plenty of increasing evidence that individual and community viral load suppression matters. It matters to the individual, but it also matters to that getting the epidemic under control. But even for those who felt the preponderance of evidence were showing that this matters, there was a question of, but is it ever feasible? Are we ever going to get to those levels of treatment coverage and viral load community suppression that will matter enough to drive down incidence? And so under that context, there were 4 Universal Test and Treat randomized, community randomized controlled trials that were initiated in Africa. They're listed here, and we'll talk a little bit about them in the next couple of slides, but they covered Uganda, Kenya, Botswana, Zambia, South Africa. They were in rural communities, urban communities, and peri-urban communities. And at the same time as these research trials, there were also, intensive innovative programs going on. In particular, this project by MSF, I haven't said it in a long time, Mbongo-Wane project, that were also trying to achieve the same thing. And this just graphically shows where those 4 studies were, most of them starting in 2013. And so, they were really asked to sort of pose or prove these questions about what does it mean to be universal? First of all, can you actually do it? Can you get to universal treatment? Is it even feasible? If you get there, will it work to actually drive down community incidence? And if so, how fast can you do it? Can you do it in 3 years? Because if it's just going to be at the same pace we're already gaining ground, why bother? Why bother to do something that intensive? And beyond the can you do it, all of these researchers, and they've worked quite well together, had to say, well, but how would we do it? How do we design what people want to where we will get a universal coverage? And we'll talk a little bit more as we go through the presentation, but this really was entailing huge and meaningful partnerships between researchers, ministries of health, community-led organizations, really relied on the collective wisdom on the ground, paired with the collective wisdom of science and experience, and putting it all together to try to reach 100% of people. And so these results have been presented in a lot of places over the years. So I'm not going to go into a detailed presentation of the study results and the study methods, because what I really want to do is to be able to fast forward to, but now that we're in 2021, what could that mean for programs? What does that mean for real life application? So in that mission, I'm going to do what sometimes my team hates, and I'm going to go right to the results, right to the end of the story for the studies and say what they found. Well, across these 4 trials, they found that, yes, it's feasible to rapidly achieve very high community coverage of treatment. They found that by doing so, the study saw decreased HIV incident at the community level by 20 to 30% in just 3 years. And moreover, they also saw a decline in HIV-related mortality by about 20% in just those 3 years of implementing. And I should say 3 years of implementation was not a full 3 years. That was from startup to getting everything really working well and following through. They also found that retention in HIV treatment at 12 months was extremely high, including for people who elected same-day initiation of HIV treatment, something that was rarely policy at the time. And they showed that these methods really could rapidly impact population-level viral load suppression, surpassing that number of 73% of people living with HIV being virologically suppressed. And they did this by reaching and connecting substantial numbers of people who were those most likely to be missed by the routine and regular services. Across the studies, they tended to find the men, the young people, and others who weren't routinely accessing the health facilities, or those who are often not home during routine community health worker visit hours. And this just shows a few of the highlights from those studies. The green bars on the left show the first 90 and the second 90. The lighter color is at the beginning of the study, and the darker color is at the end of the study. And you see that all of those studies, all 4, surpassed the first 90 by the end of the study. And for the second 90, all except the task study very much suppressed the second 90 as well. You see the numbers 97%, 95%. And I haven't even shown the third study, the third 90 here, because those also were all very good. But in some cases, like Botswana, the third 90 was 97% to begin with. For people who were on treatment, 97% were virologically suppressed. But what changed and shifted across all of the studies was, by virtue of achieving the first and second 90, the community population viral load suppression accelerated greatly. And that's the blue bars at the top there. It shows you population viral load suppression from the Botswana study was up to 88%. By the search and HPTN, it was 74 and 79%. And that was a very dramatic achievement, particularly in just 3 years. And in the bottom, you see how those results at the end of the study compared to the non-research context of how other countries who weren't participating, or national numbers as a whole, were at the end of those studies. Nowhere near the same level of population viral load suppression. Some of the other things that the researchers found, As I mentioned, there was a 22% reduction in mortality, and this here happens to be the search data in just 3 years. And this is because even in communities where treatment coverage was already pretty good for the time, they still found a large number of people who had low CD4 counts but weren't in care and weren't under treatment. Another query that sort of pop art, the HPTN trial asked them, says, well, they sort of looked back and said, well, now we have a lot more partner testing or index testing going on. What if we had been in the same communities at that same time and done partner testing instead of this universal testing? And what they found in this case is that, yes, they would have greatly reduced the number of HIV tests they had to do, 90% fewer tests. But in this specific cases, they would have missed over 80% of those undiagnosed people with HIV, because the people being missed were not people who were routinely connected to other people who knew they were positive. And then finally, the third analysis below under pop art really shows that this kind of intervention continue to have benefits over time, benefits for HIV incidence reduction that are cost effective, although not cost saving. It still takes money and investment to deliver these. However, as we talk about some of the models, it's important to recognize that this is just the cost effectiveness for HIV. Considering many of the strategies are multi-disease intervention strategies, you can imagine a time that if there were shared investments for this strategy, shared across the many disease areas that could benefit from it, it's possible that the cost effectiveness and the efficiency would grow even further. So then, here we are going into 2021. And taking up these studies that for the most part were 2013 to 2018 that have not been rolled out really programmatically in wider ways since then. And it really begs the question of what could be. What could UTT in real life look like? And this is what we're calling Universal Test and Connect. And to really weigh that, what could it be? It requires putting together many of the lessons learned in the studies with what we experience in real life for programs. And that's the how. And I'm going to go through sort of blending what was learned in the studies and what some of the thinking for programs are, because even though there is a lot of good publication out there from the UTT trials, many of the ways that these teams shifted and redesigned and changed how they were doing things and what they were doing, that's not what always captured very well in a science paper. But those are sometimes the elements that you need to understand to do a good translation to what would it take to do it in real life programmatically. And so we actually posed this question to a meeting of experts in December 2019. And the participants included the UTT trial team experts, but also we brought in a lot of thought trust partners, civil society and community-led representatives, government officials, modelers, health economists, HIV prevention experts. And of course, we had technical and funding partners there as well. And our goal was to bring in folks who were not already convinced that this is something that should be done. We wanted a lot of questioning and unpacking and challenging of what would it really take to do it, and does it make sense to do it anywhere? And so I'll go through a few elements of where we landed and bringing in some of the experience from the trials themselves to illustrate how we think about it or could be thinking about this going forward. So first of all, what is Universal Test and Connect, UTC? Well, we're proposing that it's an intensive community-wide strategy that really can accelerate HIV epidemic transition by rapidly reducing new HIV infections and also rapidly reducing deaths from AIDS. It is meant to be an additional complementary strategy towards specific communities or subnational areas for rapid impact. It doesn't replace some of our core services. And it absolutely relies on a few things. Community-based, people-centered approaches that reach people who are not accessing healthcare facilities. It has strong connections to services people want to be at, high quality and respectful services. And the researchers will tell you, done this way, it actually also really transforms community acceptance and engagement for HIV and also for health writ large. Probably something that is also important in our COVID context. So, but what's really different about UTC then, and this is sometimes hard to describe in shorthand. It's nice to have that sort of global picture that, yes, it takes Universal from theory to practice. I should mention that I think when the UTT trials were being done, most of the focus was on that universal treatment. And I think we discovered once we got Treat All that one of the biggest barriers to that universal treatment in many countries is that universal knowing your status. And so UTC is not a generic, general blanket approach to a community, but in fact, it works iteratively to find out who in a community has not been reached yet. And it uses that community wisdom and data and flexibility and adaptive services to reach those people who are missed. Sometimes you have to say what it's not to understand why it's different from what we already have, because when I go through some of these elements, it's going to sound like everything, well, yes, that sounds familiar, that strategy sounds familiar, that service sounds familiar, because it is really a combination of existing approaches. But it's not just a new name for existing approaches. It's not just a new name for Treat All. It's not just a new name for sort of the previous or old-fashioned mass testing campaigns that many of us have been through. And it includes some of these same labels in some ways or activities. It might include some door-to-door work or multi-disease fairs. But what is different is it really does specifically reach those who have been persistently missed. It avoids what we've experienced for a lot of years, which is overreaching people who are most available and convenient, reaching them multiple times. And instead, it adds a level of precision and adaptability that finds those who have been persistently missed. It's got a fundamental focus on linkage and the quality of the services, as I mentioned. And I think especially when we go from the trials to program, enhancing this continuum of care for prevention services is also key. And importantly, it has this concept of an initial activation or enumeration of households. I'm going to talk a little bit more about that because sometimes it can sound like it's just a research strategy and it has no bearing on programs. But really, this activation and this adaptability or iteration is about knowing and reaching those who've been routinely missing. So activation of households really provides information and choices across the community. And enumeration or a census of the community is part of that. You know, you have to know where, you know, how many households and individuals are around and who they are. So even if you're not tracking individual people, you get a sense of, okay, in our community, we've got 1,000 young men aged 19 to 25. And so as you roll out services, you can sort of figure out, have I reached those 1,000 men or not? From those who've rolled it out on the ground, they'll say activation also keeps people safe. It has that universality that builds peer trust with the community. And it also increases HIV and health literacy up front. That activation, engagement, census taking gets people and households interested in the new prevention services. It can share new insights that they might not have heard of that are motivating, like undetectable equals untransmittable. It has provided other services by design in a community for what is going to matter to that community, like hypertension screening or contraceptive services. And you can imagine a situation where that activation includes COVID services and COVID education and COVID resources. Now, iteration, there is this dynamic and adaptive response during implementation. So the design across each of these studies was really about having almost an initial round of services that tried their best to blanket a community, but then the follow-up, the subsequent services were really designed and delivered in response to who wasn't reached initially, or who maybe really need to be reached over and over again because their specific risks and needs. And community leaders have been incredibly critical to helping understand and mobilize to reach those specific missing people and populations. So strategies that were used, again, might sound familiar, but they were adapted based on who you still needed to reach. So multi-disease strategies, hypertension, diabetes screening, etc., visiting specific households on evenings and weekends. And I used to challenge the researchers originally. I said, you cannot convince me you reached 20 to 25-year-old men by offering hypertension and diabetes screening. I just don't believe it. And they're like, oh no, we had an everything you ever wanted to know about sex tent that people could come and talk and ask us all these sensitive questions. And that's where the young men came from. Like, oh, that makes sense. And importantly, that agile and adaptive services synergize very completely with the in-facility approaches. Again, the focus is not duplicating the services people are already receiving, but reaching those who might have concerns or might have been avoiding those services to begin with. So the third question that comes when we think about translating this to programmatic is where? What communities should we consider for this kind of intervention? And definitely the consensus message from that consultation is that UTC should not be applied everywhere. It is incredibly resource intensive. And by that, I don't just mean money intensive, but really it's human resource and thinking and agility intensive. And it's probably not the strategy for low HIV prevalence or low HIV incidence settings. So considerations of where might want to think about knowledge of status, community levels of unsuppressed viral load, areas where community viral suppression is low and mortality remains high. And this graph here just was Avenir Health tried to do some mapping of where it might make sense. If you mapped on the x-axis HIV prevalence rates and the y-axis knowledge of status, and you see, if you have low knowledge of status and low HIV prevalence rates, which is that peach color in the corner, you know what, no matter what you do, you're going to start to find people. You need to have some good evidence-based testing approaches, but probably don't need community-based testing unless it's a really high prevalence area. By the time you get to really high knowledge of status, and that's the green area across the top, then index testing will be more and more useful. With community-based testing, probably should be targeted in specific sub-regions where there's gaps. And then I think that middle of the ground, where prevalence is getting high and knowledge of status is medium, but not all the way there, this is where filling in the gap with strategies like this might really matter. And I tell you, it doesn't mean that these are the only communities to consider, especially as we're learning more and more under COVID. Are there possibilities that in a lower prevalence country, you have neighborhoods and urban areas that happen to be higher prevalence, or that can combine a network approach to a geographic approach to find the people who aren't being found? Can you consider a more limited universality in some communities? If the gaps are really young people or men, could you really gear the universality to a generation as opposed to the whole community? These are unanswered questions. But another thing to think about in terms of getting the community ready to benefit from this kind of strategy are what we designated as policy and practice essentials. Hopefully many of the things listed on this slide now feel normal to a lot of people for your community. But at the time the UTT trials were coming up, they were hardly the norm. I think even as early as our sort of COVID expansion, we know many of the things listed here in terms of differentiated service delivery, even multi-month dispensing, might have been policy, but they were hardly at scale in many countries for implementation rollout. So the list of these things here, they're all best practices, they're all parts of guidelines, but it's highly recommended that if you're going to try this strategy in a community, even if at national levels these things are not the norm implemented across, you need commitment from the healthcare services, from providers, from community, that we're going to do our best to get these things to be the norm in this community for the strategy to work. And at the bottom, very important, is this idea of real-time data that's exchanged between health and community to really target the what next part and problem solving of the response. The course correction is key. So does COVID-19 make UTC more or less desirable? I actually think it sort of provides new options and potentially new demands. Some of the elements that were achieved through UTC, community trust, acceptability, engagement, those things certainly seem to have value when we talk about COVID test and trace, COVID vaccine preparedness, and ultimately delivery. They certainly seemed to grow when multi-diseases that are also comorbidity for COVID were included in the outreach, from blood pressure to diabetes to TB screening. Activation and enumeration as described seems like it's also useful to those priorities within COVID-19, community trust and acceptability. And in some cases, the communities where this strategy makes the most sense align with communities that are high priorities and sometimes under reach for COVID. So dense settings like informal settings in high density suburbs and slums and high HIV prevalence countries. And certainly in COVID, many of you are part of strengthening community facility linkages. But finally, I think, even in the trial setting, this wasn't easy. It required community and health services to be very much aligned, excuse me. Community services and facility services to be linked, dynamic, regular sharing of data that I talked about, as well as joint problem solving. Now, in the study setting, this was achieved because it was pretty high profile. So this in program takes a lot of leadership commitment to make it happen. So now what? How can countries take elements of the UTC package forward? How do we create demand and explore resources for UTC? Can we start small? Can we do this in one city or among one population in a country to show that programmatically we can roll it out and to get really that momentum for more? And so I guess my question for everybody is, who's willing to try? 2021 is definitely a special year for UNAIDS. We are still full on for the 2021 to 2025 new target setting. And those targets will maintain urgency about how we not only get back on track for 2030, but do it in a way that's going to hopefully accelerate our recovery from any lags from COVID. This is a year where the post-2021 strategy for global AIDS in the world is being created and will hopefully be signed on to by member states in 2021. Of course, we're still in COVID-19. We have HIV. We have pandemic preparedness and response on the agenda. We have UHC still on the agenda. We know COVID-19 is far from over, that we will need rapid recovery as mentioned. But I think also, it's more clear than ever that failure to invest in health, failure to do some of these intensive things that pay off for the long run, is a poor choice of investments. It risks economies. It costs more in the long run. So even if we're going into a time of economic austerity, I think I challenge us to continue to think big, think new, think different in our investments, think about how we pull communities and services together in a new way and around some joined up purposes that we know are going to pay off for people in health and are going to pay off for getting on top of the HIV epidemic for the long haul. So thank you to everybody. These are just some links to some of the original studies, and I might have truncated a few of them so I can get some updated links to the organizers. So thank you, and back over to our chairs.
Thank you, Dr. Hader. It's great to get insight from somebody sort of really involved and seeing this at such a high level. And I think the impact of COVID on our epidemic, our favorite epidemic, cannot cannot be underestimated, and we do need to rise to that challenge. So we will be right back with our prevention track session in a minute or so from now.